Kiran, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the National Guidelines for HIV Care and Treatment 2021. Today's topic is Advanced Disease Management in PLHIV and Prevention of Opportunistic Infections. Speakers are Dr. A.K. Puri sir from NACO, Dr. Rewari sir from WHO SEARO, and Dr. Ramesh Allam sir from CDC India. We welcome you all for today's session. Dr. Puri sir is unable to join today's session. I now request Dr. Snehalata from NACO to please give the opening remarks and welcome the speakers again.
Good afternoon, everybody. Myself, Dr. Snehalata Roy, ACCSD. So actually our DDG sir and ADG men could not join us today. So on behalf of them, I welcome you all to the session on advanced disease management in PLHIV and prevention of OI. So now I hand over the session to Shweta for pre-test. I hope you all participants have a good learning. Thank you.
Thank you, ma'am. We shall quickly go through the pre-test. Kiran sir, can we have the pre-test, please? Thank you. Participants are requested to please attempt the pre-test. It is visible on your screens now. There are 5 questions in all. Each question has a single choice, so you have to choose one answer for each question. Please scroll and attempt all the 5 questions. We just have 5 minutes for the pre-test. The first question is, definition of advanced disease, HIV disease among adults and adolescents includes presenting with CD4 count less than 200 cells, presenting with CD4 count less than 200 cells and WHO stage 3 disease. C, presenting with CD4 count less than 200 cells and WHO stage 3 or 4 disease, and children younger than 5 years of age who are not on ART. Question second, which is the most common OI in HIV in India? PCP, TB, toxoplasmosis, gastrointestinal OIs. Third question, which of the following is not included in package of advanced HIV disease management? Systematic screening for CRAG, fluconazole preemptive therapy for CRAG, positive people without evidence of meningitis, home or community-based follow-up, reimbursement of travel expenses case-to-case basis, early tracing for anyone who misses an appointment. Question 4, which of the following statements is true for CPT? CPT is not recommended in pregnant and lactating women. Initiate ART first and after 2 weeks start with CPT.
Sorry, Shweta, we cannot hear you.
Yes, sorry, ma'am. There was a power cut. Sorry for the interference. Question number 4, which of the following is true for CPT? CPT is not recommended in pregnant and lactating women. Initiate ART first and after 2 weeks start with CPT. Cotrimoxazole desensitization should be attempted in PLHIV with a previous severe reaction to cotrimoxazole or other sulfa-containing drugs. No specific laboratory monitoring is required in patients receiving cotrimoxazole. Last question. Following are the criteria for discontinuing fluconazole primary prophylaxis, except person is adherent to ART and free of cryptococcal disease, fluconazole given for at least 3 months, CD4 cell count less than or equal to 100 cells, and suppressed plasma viral load, that is plasma viral load less than 1000 copies per milliliter. Participants are requested to quickly go through the pre-test. We have another 2 minutes for the pretest. Kiran sir, we can end the pretest now. I now request Rewari sir to please continue the session. So you can start sharing screen from your end. The screen is visible. So you'll have to unmute.
Good afternoon, everyone. At the outset, I would like to congratulate NACO for having taken this great step of updating ART guidelines, not only for treatment, but also opportunistic infection and operational guidelines. This was a mammoth task, which took almost a year, but in whole of Southeast Asia, India is the only country which has got fully updated guidelines available and only country which has got operational guidelines in such details. Also, in Southeast Asia, India is the only country which has got 80% of its all PLHIV on DTG based regimen, which is a thing we must congratulate NACO. So to begin with today's session, I would like to thank NACO again for giving me this opportunity and ITEC, not only for this session, but a series of sessions that are being supported by different people. And when I joined yesterday, there were more than 200 logins. I know there would be 3-4 people at each login, and I think we'll increase it further today also. So to begin the topic on advanced disease management among PLHIV. So by end of this session, participants will be able to define what is advanced HIV disease, how does it differ in adults and children, why do we want to have a special session or a chapter on HIV disease management when we know that every PLHIV has to be managed using the standard guidelines, and what are the components of package of advanced disease management, what are things included which are in addition to those all PLHIV should be getting. We know that globally there was a target of having less than 500,000, that is 5 lakh deaths which are related to AIDS by 2020. And we are now in 2022, but in 2020 itself, we had 680,000 AIDS related deaths. And if you see from the graph, from the curve, the decline has plateaued over last few years. So it means our efforts need something different push to bring down these deaths. We all know that early detection is key to reducing deaths. That is a very important component because when people present at a late stage, they will have lower CD4 count, they will have more severe opportunistic infection, multiple opportunistic infection. Consequent to that, there will be hospitalization, poor quality of life. And even when you present at low CD4 count, your optimal response to ART will be suboptimal. So all these things, when a person presents late, this leads to a poor prognosis, increasing the mortality. And also, If you're presenting late and you are not adequately suppressed, the transmission to spouse and sexual partner chances also increase. And as you learned yesterday also from Dr. Anuradha, that over the years, that guideline, and you all know that guidelines on when to start treatment based on different studies have been changing, and treat all has been implemented since 2016 globally, and 2017 NACO also adopted this. But despite that, we continue to have large number of deaths. So what additional component is required? So we have to think what can be done beyond early detection, beyond treat. Even if we are treating everyone, detecting them early, how to reduce mortality further. Because we know that people who present with a CD4 count of less than 200 at baseline, and if you compare them to those with CD4 count of more than 200, their chances of mortality are 50% high. And that is on the first 3 months of antiretroviral therapy. And this is data from low and middle income countries on managing advanced disease. If we really look at this graph, and you see even presently in countries which have got large treatment programs, like South Africa has got almost 6 million on treatment, there also still people, 1 in 3 people are starting with CD4 count of less than 200. And 1 in 5 people are presenting with CD4 count of less than 100. And some of the Central and Sub-Saharan African countries, it could be as high as 70%. Late presentation occurs everywhere. This is a study which is published as in IDEA and Cohort study, published in 2017 by Carmona et al., which is an analysis of 46 countries, which include a mix of the low-income countries, middle-income countries, and upper-income countries. And also a gender differentiation has been seen that in these 46 countries data, 31% of patients starting ART with advanced HIV disease, that is when CD4 count is less than 200. And if you really look at median CD4 count, at the start of antiretroviral therapy, this is a collaborative study of treatment programs published in Clinical Infectious Disease in 2018. If you see, even among male and female, the presentation among male was at a lower CD4 count compared to females. And also in all strata of income, people still presented with a late presentation. Let us focus to our country. We know that India has got 2.3 million PLHIV with a national prevalence of 0.22%. And recent estimate from a middle income setting, they suggest that 30 to 40% have got, I think I've already dealt this from the South Africa. And if you see in India over the year, this is the data from 2005 to 2018, how the CD4 count at baseline, median CD4 count has been increasing from 170 to 274 in 2018. And just focus on this. This is the CD4 distribution in 2019. People with CD4 count less than 200 at baseline, 35% of the patient. Patient with CD4 between 200 to 350, 26%, 350 to 500, 18%, and more than 500, 21%. So if we focus on this 35%, these 35% of patients who present at baseline with CD4 count of less than 200 will have a higher mortality even within the first 3 to 6 months, despite timely initiation of antiretroviral therapy. So our focus is basically how do we manage this? So that is the need that we want to have a group of people called advanced HIV disease. So we can have different categories, people with a good CD4 count, people who are stable on ART, people who are faulting on treatment. But we want to have another category, which is people with advanced HIV disease. And by definition, for adult and adolescents and children older than 5 years, advanced HIV disease is defined as CD4 count of less than 200 cells or a WHO stage 3 or 4 event. And this includes not only the new patient who present to us after detection, that is called ART naive individuals, but those also who interrupt the treatment. There are people we know that who stop treatment, who are lost to follow up, and then they come back to care, return to care with a lower CD4 count. Even those people will require same intervention compared to those people like those who are ART naive. So all children younger than 5 years who are not already receiving ART and are clinically stable are still considered having advanced HIV disease. And when we say CD4 count less than 200 or WHO stage 3 or 4, it is important to mention that relying on clinical stage alone will miss many substantial number of people. We know that there are challenges in basically relying on clinical staging, the capacity at the centers, the recording. We know this from the data that recording may not be very correct. And we also may have people who are in stage 3 or 4 uh, who have CD4 count less than 10, or there are people who are absolutely fine having CD4 count of 10, 20, 50, but they don't have any clinical illness. So they will be basically clinical stage 1 or 2 at the most, but their CD4 count will be less than 200. So CD4 count at baseline still remains essential, but I would like to emphasize, and you all know that this is not required for initiation of ART. This baseline CD4 code is required for differentiating people into those with advanced HIV disease, because these will be group of people who will require certain additional interventions so that they don't die within first to 3 to 6 months. We know that people with advanced disease, basically they present with different opportunistic infection. They have increased risk of iris, because when we start antiretroviral therapy and there is immune reconstitution, they will have iris, and they can have opportunistic infections like tuberculosis, cryptococcal infection. So they are at increased risk of different opportunistic infection, AIDS-related deaths, and comorbidities. So these people basically require frequent monitoring, and that becomes a additional burden to the health system if they have to be hospitalized again and again, or if they have to visit ART center more frequently. So by identifying people with advanced HIV disease, we can focus them on in a different way, in a more focused way, to reduce mortality among them. This is just a study published by Ford et al. From WHO and Lancet 2016, which did a meta-analysis of 70 studies, and they found that there are mortalities higher in those advanced disease, and they try to find out the causes, what are the infections that cause mortality among these people. And to summarize that, basically, causes of mortality in people with advanced disease are tuberculosis, severe bacterial infection, cryptococcal meningitis, toxoplasmosis, PCP. Among children, this could be tuberculosis, severe bacterial infections, PCP, diarrheal diseases, and even malnutrition. So when we talk about advanced HIV disease, we have to basically focus that how can we prevent these severe opportunistic infection, and if these are present, how can we basically manage them well so that people are benefited with the antiretroviral therapy. So what can we do additional? So focus of this talk is what additional interventions can be made to prevent and manage. If it is they are already in advanced HIV disease, how to manage that. So these are the two studies I would like to share. I will not like you to go into great details of this, but these are the studies called Reality and REMSTART studies, which form the basis of advanced disease interventions. These study, the Reality study was done in Kenya, Malawi, Uganda, on 1800 patients where CD4 count was less than 100. And all these people, in addition to provision of ART, were provided number of drugs that included cotrimoxazole, INH, B6, fluconazole, azithromycin, albendazole. And these were based on the opportunistic infection that were prevalent in that area. And then it was seen whether providing so many additional drugs, what would be the problems in terms of pill burden, in terms of side effects of drugs, in terms of cost. So a cost-effective analysis was done, and it showed that provision of these drugs is cost-effective and also helpful in reducing the mortality. Similarly, this study, REMSTART study, was basically done in Tanzania and Zambia on 2,000 individuals with CD4 count of less than 200. They were all provided with rapid ART initiation, cryptococcal antigen, additional adherence support for 4 weeks. And again, this showed that there was an additional benefit in terms of reduction of mortality in both the studies. So some of the papers that got published from these studies concluded that there is a 28% reduction in deaths, improved adherence at 6 months when you provide these additional intervention. And another study showed that there is 27% reduction in death and reduction in incident mortality and reductions in hospitalizations. So the package of advanced HIV disease management includes certain things, which includes differentiated care, means you prioritize these patients with advanced disease in terms of, and also include these evidence-based intervention which come from reality and Ramstal trials that screen them, treat them, or provide prophylaxis for major opportunistic infection, start ART rapidly, provide an intensified adherence support so that we are able to reduce mortality and mortality among these people. So what are the components? So these are the 5 key components of advanced disease package of care. Screen for tuberculosis, active disease, and you all know how to screen. Basically, it is 4 symptom screen, X-ray, prompt initiation of anti-TB treatment or IPT. Once you have ruled out tuberculosis, you need to provide TB preventive therapy. And they also suggested having a test called LAM test, urine test for LAM, which can detect TB, particularly among those which have got CD4 count of less than 100. Systematic screening for cryptococcal antigen, fluconazole preemptive therapy for those who are positive but do not have evidence of meningitis, screening for cotrimoxazole prophylaxis, rapid initiation of ART, and adapt adherence support and intensive follow-up. So these are a little bit details about the components. So we'll first go to the prophylaxis or preemptive treatment. Cotrimoxazole prophylaxis guideline remain the same, which are for others that at any CD4 count of less than 350 or a clinical stage 3 or 4, we provide CD4 count and provide till the CD4 count has gone beyond 350 on 2 different occasions. And this application, this recommendation is for adults, adolescents, children, everyone. Similarly, if you have excluded tuberculosis using 4 symptom screen, X-ray or urine for LAM, then TB preventive therapy is to be provided. Presently, the program provides INH therapy, but we are moving away from INH to a weekly therapy, basically with INH and rifampicin. So this is also to be provided at any CD4 count once we have ruled out tuberculosis. Then fluconazole preemptive therapy for CRAG antigen positive. So we do a cryptococcal antigen lateral flow assay, and those who are positive but do not have signs of evidence, we provide them preemptive therapy. Those who have got signs of evidence of meningitis, we give them full treatment for meningitis, which includes induction therapy, maintenance therapy, and then you start ART. If cryptococcal antigen is not available, basically we provide CD with fluconazole therapy for all those who have got CD4 count less than 100. Rapid initiation should be provided to all people, whether they are adult, adolescents, or children, at any CD4 count. But we can just defer if there are clinical symptoms or signs suggestive of meningitis, either a tubercular meningitis where we defer by 2 weeks, or cryptococcal meningitis where we defer the treatment by till the full time of cryptococcal maintenance therapy has been given. Then we have to adapt tailored counseling to ensure optimal adherence to people with advanced disease, and that should include a home visit as required or feasible based on the need based. So this is a flow chart which is available in the operational guidelines also, how to identify and enroll the PLHIV for advanced disease management. And this is a complete figure, but I'll go through some parts of the figure in a sequence. So whenever a PLHIV visits ART center, we know that flow is to go to a care coordinator, counselor, nurse, and doctor. And the care coordinator will do a 4 symptom screening, but the counselor will basically focus on any children who are less than 5 years, who have got current symptoms, which are cough, fever, weight loss, or poor weight gain, or night sweats. These are the typical 4 symptom screening for tuberculosis, but also additionally ask for headache, difficulty in breathing, chest pain, hemoptysis, paralysis, or seizures. Basically, we are trying to look at stage 4 diseases by headache. We are trying to rule out cryptococcal meningitis, paralysis, seizure, toxoplasmosis, chest pain, or their CD4 count is less than 200 or viral load is more than 1000. But we don't do a baseline viral load. This viral load indication is for those who are returning to care after being lost to follow-up or after stopping treatment. Then the nurse will have to again do this 4S TB screening and symptom screening. This has to be done at all stages. And then nurse has to assess, because counselor may not be able to assess these things. Nurse has to assess on the temperature requirement. If temperature is 39, with headache, respiratory rate is high, more than 30, heart rate is more than 120, or saturation is dropping. Then the patient goes to medical officer for similar evaluation, particularly for serious signs. And medical officer also confirms these serious signs, that these are signs of serious illness. They also see for signs of cranial involvement and confirms advanced disease. So if there are any signs of serious illness, cranial involvement, then the person is referred to an expert in the same institution or to a higher priority center. If a person fulfills the criteria for advanced HIV disease, then we go for the same package of intervention that you see on the right. But if there are no signs of advanced disease like CD4 count less than 200, clinical stage 3 or 4, or child less than 5 years, then we provide standard package of care. So initial screening and triaging is very important, because person has to be tried in the beginning, not that he has to go through all the steps. If he's having high temperature, high respiratory rate, low saturation, heart rate more than 120, is unable to walk unaided. He may have difficulty in walking, may have seizures, history of seizures, deterioration of vision. So these are basically signs of serious illness, which counselor should immediately fast track. Nurse should fast track to medical officer, and if present, they should be referred to a specialist in the institution. Now coming to screening, we know that we discussed that we need to do screening for particularly for tuberculosis and also for cryptococcal meningitis or cryptococcal antigen. Because TB we know is the leading cause of mortality, so it is very important that all PLHIV are screened for tuberculosis, and ART should be initiated in all PLHIV with TB regardless of CD4 count. But timing we really need to consider, and as per recent guideline, they should be provided within 2 weeks. And if your CD4 count is less than 50, the TB treatment and ART can be provided simultaneously. So among co-infected patients, if there is a tubercular meningitis, ART should be delayed by at least 4 weeks, can be initiated in 8 weeks after the treatment for TB is stabilized. Again, we have to look for, fever, chronic headache, altered mental sensorium, other neurological problem. Patient is unable to walk unaided. So we have to look for basically cryptococcal disease, toxoplasmosis. These are the conditions that we really need to look into it and start prophylaxis. So these are 3 important prophylaxis basically. Cotrimoxazole prophylaxis is given to prevent severe bacterial infections and also pneumocystis carinii pneumonia or pneumocystis cerevisiae pneumonia. CPT must be initiated in all PLHIV infected adults, adolescent with CD4 count of less than 350 or stage 3 and 4. So this remains the same. Isoniazid preventive therapy, we actually call this as TPT now. TB preventive therapy is to prevent development of TB, and this should be given to all those who are 4S negative. But presently the program supplies INH only, that is why it is written IPT. But the guidance will come very soon to provide INH and rifampicin also. Some pilot is going on the same. Again, to repeat, fluconazole preemptive therapy to prevent development of cryptococcal meningitis in persons who have got antigen positive without meningitis, or fluconazole therapy when test is not available should be provided if CD4 count is less than 100. So if person has got signs of meningitis, do a lumbar puncture, confirm meningitis, provide treatment. No meningitis, cryptococcal antigen positive, provide fluconazole preemptive therapy. If there is no facility, which presently there facilities are not available for cryptococcal antigen screening, then you provide a fluconazole primary prophylaxis if CD4 count is less than 100. I hope that is clear. So in addition to all those that we have talked, again, we know that there are challenges when we provide them fluconazole, we provide them cotrimoxazole, we provide them IPT, we provide them B6, and then we provide them ART. So that the challenges of pill burden set in, the challenges of drug-drug interaction also come in at that time. And persons may have certain side effects which may be because of polytherapy. And then Obviously, they have to come more frequently, so travel costs. So these are some of the challenges which must be actually addressed. And after discussion with the client, we should form a protocol for each of the person that suits his lifestyle, his timing, other things. If you were participated in the yesterday session, Samina had taken a very good session on adherence to ART, and that included all these challenges. Particularly, challenges are there for children, there are challenges for adolescents, pregnant women, people with travel, people who are on night duties. So you have to actually devise a, a protocol for individual patient that basically addresses their own lifestyle and challenges. And of course, we know that the solution lies in treatment literacy, outreach through community care center, peer support, and intensified adherence support. So such complicated cases who present with signs of severe illness should be referred to a higher center, not necessarily a higher center, but if facilities are available within your own centers. But most of these cases might be managed as an indoor patient, and once they are stabilized, they should be referred back to ART center for continuation of antiretroviral therapy from their own center. Coming back to a very important component of rapid initiation of ART, basically, rapid initiation, the guidelines say it should be offered to all PLHIV following confirmed HIV diagnosis. It is defined as starting ART within 7 days from date of diagnosis, and people with advanced disease should be given priority for assessment and initiation. You know, in our country, basically, we say we don't prioritize, basically. We give it to everyone, give the same kind of adherence counseling, give the same of counseling. So that is why that those with advanced disease require a different kind of counseling, a more focused counseling. So we need to identify these patients and provide them the counseling and treatment literacy required. 7 days is generally a recommendation. This is not a kind of deadline that you cannot do it in 3 days, you cannot do it in 5 days, or you cannot do it in 10 days. We know that ART initiation has a underlying principle: patient should be prepared. And we know what are the steps in ART preparation. That patient understands is a lifelong therapy. Patient understands that drugs have to be taken regularly with more than 95% adherence. Patient understands that the treatment is lifelong. He also understands that there would be some side effects, but these subside after some time. He has also to understand that he does not have to share the drugs with anyone. And he also understands what are the drug-drug interactions so that he doesn't take like vitamins or antacids along with the dolutegravir. But patients who are prepared, who are ready to start, ART initiation can be done on the same day also. This is just to show you some of the evidence. Basically, these are the studies which came. These are meta-analysis of again studies which show the benefit that there is a consistent evidence of improved clinical outcomes, including reduced mortality among the studies. More patients initiated ART within 90 days when they were actually tries to receive anti-advanced disease care, and retention at care in 12 months was higher, and the viral suppression was also higher at 12 months. So rapid initiation, people who have no contraindication to rapid ART initiation, they should be fully informed the benefits of ART offered within 7 days, and adequate preparedness counseling should also be given. Persons with low CD4 count, rapid ART initiation is very important, because these are the people who have higher mortality, but they will require more close focus monitoring also. Among CLHIV, again, rapid initiation is advised, preferably within 7 days, and appropriate counseling is most important. People who have no clinical sign and symptoms but TB or other opportunistic infection, they can be initiated on ART in the same day in combination with other drugs. So key actions, what are the key actions that basically we need to take when we are managing patient with advanced disease? And these actions are related to intensified tailored counseling support. So people need to be provided additional counseling on the additional drug they are being provided in addition to ART, like drugs for PCP, fluconazole, and they should also be told that if they miss on the treatment, they will be immediately tracked through a phone or through some home visit. In case because of COVID or some other restrictions, face-to-face contact is not possible, a distance contact through telephone consultation, mHealth, text messaging, there are a number of options which can be considered and are being followed in the some of the states as we have seen. But it is more important that ART staff himself actually familiarize themselves with the new counseling message on 4 key areas. What is rapid ART initiation? Why do we need viral load monitoring? What is a differentiated care and advanced disease management? And the concept of U equal to U, that is, if your viral load is undetectable, it means it is untransmissible. So I think that was all on the advanced disease management. And then we have a little more details on prevention of opportunistic infection. And I would request Dr. Ramesh to come in at this stage. Thank you.
Thank you, sir.
Thank you, sir. So please allow me to share my screen.
Yeah, please go ahead.
Thank you, sir.
Good afternoon, all. Good afternoon, sir. And sir had already briefed us on the prophylaxis part where it comes in the advanced disease management package of services. And in summary, we have also seen where it is indicated. In the next coming slides, we will see some of the indications, and if at all there are certain contraindications where we cannot use them and where definitely we need to use. Next slide, please. Yeah, so the opportunistic infection is that which occur in a person with HIV, either because of decreased immunity in that person. And as we see and have already seen in the previous slides, the opportunistic infections are those which are primarily responsible for the morbidity and mortality. And we can see a clear relation between the CD4 count and the opportunistic infections which the patient may have. For example, if you have a very lower CD4 count, then we would tend to get most of the stage 4 infections there. And if you are again having somewhere between 100 to 200, we estimate, or we could guess some of the OIs which are more common in that CD4 range. And many of the OIs can be preventable and have a prophylactic or a preventive therapy. And some prophylaxis we will also have to give even after we start antiretroviral therapy that needs to be continued. So we will see what are those important preventive and prophylactic therapy that we need to take. Next slide, please. Yes, so this is a relation between CD4 count and the OIs that we expect. Not that everywhere it follows the same thing, but most commonly, if you see a CD4 count below 100, we tend to see patients presenting with toxo, cryptococcus, or cryptosporidium, PMLE, CMV, and MAC. So as the CD4 count decreases, we expect to have major OIs that are mostly part of the WHO clinical stage 4. And as we go higher up towards more than 200 and all, we see the common opportunistic infections. Tuberculosis usually does not follow any of these, and we do not have a real cutoff for that. Next slide. Right, this slide shows you what are the type of prophylaxis we are talking with. For example, whenever we say a primary prophylaxis, in the previous slides, we just have seen the primary prophylaxis for cryptococcal meningitis. And now again, we see a primary prophylaxis for PCP. That is, even before the disease has occurred, we are trying to put in a therapy that is a primary prophylaxis. If you see the secondary prophylaxis, mostly we use it, this is used for relapse or a recurrence of a disease. For example, in PCP, we use it. In tuberculosis, again, we use secondary prophylaxis for TPT. So this is a slight differentiation that we need to make between primary prophylaxis and secondary prophylaxis. Next slide. Now we go in detail about cotrimoxazole preventive therapy. Next slide. And whenever we talk of cotrimoxazole prophylaxis, there is not much change in the guidance as we have seen through years, and most of it remains the same. That is, whenever a patient is presenting with a CD4 count less than or equal to 350, then we need to start a patient on cotrimoxazole prophylaxis. And why is this so important? And what are those infections that we are attempting to prevent in this patient? Are the PCP, toxoplasma, bacterial pneumonias, specifically nocardia, isospora. So these are all some of the infections that could be prevented by prophylactic use of or primary prophylaxis of cotrimoxazole prophylaxis. And whenever there is an allergy reaction to cotrimoxazole, we have an alternative for this in terms of dapsone 100 milligrams OD, and the desensitization may be suggested for sulfa allergy. We see next slides. Yeah. And very important here, whenever we talk of cotrimoxazole and the availability of the strength of the drug is important, because there are certain sites where you just have a single strength tablet and a double strength tablet. So in a clinical practice, we actually just talk of, is it a double strength or a single strength? So this again is a double strength tablet that we need to give to the patient. That becomes very important, because you may be prescribing, but the patient may be getting something else from the pharmacy or within the hospital. So this is another very important point as part of the clinical practice that we continue. And when do we initiate cotrimoxazole? Start cotrimoxazole prophylaxis first, and then start ART. It's only because we want to just see that the patient doesn't have any skin rash, which is most common with cotrimoxazole, and we just want to differentiate between whether it is because of antiretroviral therapy or because of cotrimoxazole itself. Then commencing a secondary cotrimoxazole prophylaxis. This is for all patients who have completed a successful treatment for PCP. So remember one thing, whenever we are talking of a secondary prophylaxis, the patient had actually got the disease. So we are not preventing a disease. The patient has got a disease, and now we are only continuing the maintenance of that because we want to prevent the relapse of that. So the secondary prophylaxis for CPT will be after completing PCP treatment until CD4 count is more than 350 cells. And the same principle, at least on 2 occasions, done at 6 months apart. Usually we only read one part of the definition for actually cessation of cotrimoxazole prophylaxis is you need to have at least 2 occasions having that, not just repeating it after 6 months and stopping it. Most common error that we do in most centers that we see. So now we know when to start primary prophylaxis, whom are we starting secondary, and whether we need to concomitantly start or we need to wait. That again we have clarified. Next slide, please. Right. Now, this again, most of them have the notion that it is contraindicated during pregnancy. There's the reason, again, we are specifically pointing out, and there is also a pre-test question related to it's not contraindicated. So it is indicated that is a woman, even a pregnant woman should be getting cotrimoxazole as part of the prophylactic regimen. Then if somebody is allergic to sulfa, we have already seen dapsone is another alternative that we are giving. And a cotrimoxazole desensitization may be attempted, but not in patients with a severe known rash with sulfa drugs. So this is again a very important thing to understand. That's why whenever we write that the patient has a sulfa allergy in the white card, we always ask you to grade it, at least say it is a grade 3, grade 4 type, so that next time when the patient really needs it for a treatment or so, we know that we need to have an alternate regimen for this patient. So you will, in your experience within the ART centers, you would have seen many patients coming with cotrimoxazole rash, but we usually tend not to grade it. So grading is very important because the next episode, either for prophylaxis or for treatment, it will be very useful for the clinician to look back and take a decision on either to start with dapsone or to continue with or re-challenge cotrimoxazole. Next slide, please. Right. Now, restarting cotrimoxazole, again, indicated in PLHIV whose CD4 count falls below 350. Yeah, so another important point that we need to remember for this is it's not like one time, one episode or 2 years I continue until my CD4 count rises to 350. For example, if again the patient's CD4 falls below 350, we need to again reinitiate that. And we also, when do we encounter this? Usually in times of treatment failure, or due to any other immunosuppressive agents or conditions that the patient concomitantly has. So in those patients, again, the initiation, the dosing, and when do you discontinue, everything remains the same. Okay, next slide. Yeah, this is the slide on desensitization. So very important, again, take home that we need to understand is, unless you grade this rash that the patient is having to follow this desensitization practice becomes really difficult. So whenever we have a rash, we try to grade between 1 to 4, and this grading we will discuss in length in the next sessions in drug reactions. So once we grade it between 1 to 4, then the next thing is desensitization to be attempted 2 weeks after a non-severe, that is grade 3 or less than that only we need to do. So cotrimoxazole injection has resulted in temporary interruption in its usage. Now, it should not be attempted with a history of severe cotrimoxazole, that is a grade 4 or something like TSS. In these conditions, we should not be actually re-challenging this. And if a reaction occurs, the desensitization regimen should be stopped. And once the patient recovers fully, we need to again test and try dapsone at a dose of 100 milligrams. In a nutshell, we need to grade it higher grading. That is, if it is a grade 4, we do not actually re-challenge it. And while we re-challenge between grade 1 to grade 3 after a 2-week period, then if you again there is a rash, then we do not re-challenge at all, but we actually put the patient on dapsone either for prevention or treatment. Next slide. This is the protocol and desensitization protocol. This, I think most of us have it on our tabletops, and we need to continue. No harm in referring, but this becomes important for you to follow whenever we have a patient coming with a reaction. Next slide, please. Sorry, for desensitization. Right. Now, coming to children, this again is very important that most of us do not practice it. All HIV exposed infants and children. So here they are not talking of HIV positive or negative child, and it is all children born to a HIV positive mother should be put on cotrimoxazole from 6 weeks of age, or at the first encounter with the health services. So this is very important, not immediately after birth. We need to wait a bit because the liver has not yet developed. And so here we need to give that time period of 6 weeks. And when do you discontinue in such HIV exposed? So until we exclude, or the patient or the child, when we confirm that the child is HIV negative, until then we need to continue. Then all HIV infants and children up to 5 years of age. So regardless of the clinical stage, whenever we have confirmed that the HIV exposed child is positive, until 5 years of age of that child, we continue to give, irrespective of the clinical staging or the WHO CD4 count. And only after that, after 5 years, when you want to stop, you again see the CD4 count. If it is more than 350 cells in 2 different readings 6 months apart, then we stop it. Again, to summarize, in HIV exposed, we are starting at 6 weeks. Until the HIV infection is ruled out, we continue. All positive children less than 5 years of age, we continue. And at 5 years, we look at 2 CD4 counts 6 months apart. And if it is more than 350, then we stop. Next slide. Yeah. In the next slide, we see the dosing of, So in children more than 5 years of age, and regardless of CD4 count, we start it. And as a secondary prophylaxis, after completion of treatment of PCP, if it is less than 5 years old, do not stop it. And greater than 5 years old, again, we look at the T staging, or we look at the WHO clinical staging, and the same thing we see. Next slide. This is the dosing chart. Again, you please look into whenever you are splitting the tablets or when you're giving syrup, how much of the 5 ml of syrup should be containing. So this is a small calculation that we need to do. And this again recommend to always refer up whenever we have children coming to us and give an appropriate dose. And as you see, it is against the weight of the child and an appropriate age. So weight monitoring again becomes useful in all, important in all children presenting to us. Next slide. So with this, we finish the first part, that is the cotrimoxazole prophylaxis. Coming to cryptococcal disease. Next slide. Here we have the prophylaxis, or how do we diagnose? Now, cryptococcal meningitis, when we say through the CSF culture microscopy or by detection of cryptococcal antigen in CSF, or you also have an Indian ink preparation. So these are all some of the modalities where we could see the organism or see the immunological parameters of that. Now, diagnosis is said to be confirmed, is identified in the CSF or in the CNS tissues only. Then we say, not just doing a serum crack, we cannot say all positive with a serum crack test. No, it's only the CSF, then we say it is a confirmed case. But as we go through the other sessions in OI management, we will again look through when do we put a person on full-blown treatment, when do we give a preemptive treatment, even with a serum crack, or whenever you do not have an LP within the place of work where we are. So there are certain other exceptions within the current guidelines that we have brought in to understand when do we actually label a person as frank cryptococcal meningitis. So a positive serum crack should be done and a prompt lumbar puncture to rule out meningeal disease. So these are all how we are going to diagnose. This we will see in detail in our OA management session. Next slide. Now, the primary prophylaxis is even before the occurrence of a disease. That in the previous slide, we have seen any patient who has a CD4 count less than 100 cells. In case the cryptococcal antigen testing is not available and a patient is coming to us with a CD4 count less than 100, so there we start a fluconazole prophylaxis of 100 milligrams. And when do you discontinue that? So the discontinuation is important, like how we have seen the discontinuation of cotrimoxazole. But the primary prophylaxis, it is a person is adherent to ART and free of disease, fluconazole given at least for 1 year, and CD4 count is greater than or equal to 100 cells, and having a suppressed plasma viral load. So these are all of that. It's not one of these or two of these, but whenever you do not have now viral load is taken as part of a criteria for discontinuation of primary prophylaxis. And I want you all to understand that this recommendation is in case when you do not have a crack test available within the facilities. Next slide. Now, secondary prophylaxis or maintenance is after the patient had completed the induction phase because of for treatment of cryptococcal meningitis. Then this is recommended after 2 weeks of successful treatment for meningitis. And then you also have an 8 weeks of consolidation phase with fluconazole. This again to 400 to 800 milligrams. Now, what we have it is the dose for the secondary prophylaxis or maintenance is 200 milligrams daily for adults. And this is what you will have to differentiate between what we have seen in the previous slide is 100 milligram. Here, what we see is a 200 milligram. And the discontinuation criteria remains same for all the 4 criteria remain the same. When do you discontinue either a primary or a secondary prophylaxis or a maintenance therapy, the discontinuation criteria remains the same. So the 2 differences that we have to appreciate is the first primary is before the occurrence of a disease. This is after completion of an induction phase, we are doing it. The second thing is that the duration and the dose of drug of fluconazole that we are offering. the discontinuation criteria remains the same. Next slide. Coming to TB preventive therapy, next slide. So this again, here we call it as INH preventive therapy. And whenever we talk of INH, given this is mostly to prevent even the latent infection to progress into an active disease. So in most of our sessions that we had earlier or currently in our medical officers training modules, we see that progression of a disease from 10% to 60%, that's what we want to prevent. And 60% of the patients of all the population will already have TB bacilli in them, but not a frank disease. So this is the place where the reactivation of this infection among HIV positive patients, or because of lower immunity, now this bug grows and you get a frank infection or a disease in them. So the latent infection not to progress into a frank disease, here we are giving TB preventive therapy. And it also prevents reinfection or post-exposure to an open case of TB. This again is very important in terms of whether it is an exogenous or an endogenous reactivation that occurs. But very important thing, what we need to understand is because we are giving a monotherapy of INH, it doesn't mean that we are increasing the resistance. And there are several studies that have indicated that the background resistance that we see with INH monotherapy is the same even if the patients are getting an INH monotherapy for prophylaxis. So there is no much difference between the background change in the resistant patterns of INH monotherapy and whenever we are offering this as part of the TB preventive therapy. Next slide, please. So what is the eligibility for IPT? The very important thing as part of our intensive case finding for tuberculosis, we do a 4-symptom screening thoroughly, and all patients who are 4S negative will be eligible for IPT. And very importantly, the second step is to look for any contraindications of initiating IPT. So once a patient is 4-symptom negative and we have ruled out a TB based on either a clinical screening, and if there was a suspicion, you would have done an X-ray and other investigations. Then whenever a patient is 4S positive, then we consider him for IPT. And all children with HIV more than 12 months of age who are 4S negative again are considered for IPT. Infants aged less than 12 months living with HIV who are not in contact with a person with TB and who are unlikely to have active TB during an evaluation or according to national guidelines should receive TB preventive treatment. So the only guidance that we are emphasizing on children less than 1 year of age is that we need to look for any contact history very thoroughly. As part of the 4-symptom screening, anyhow, we do it for all children. The change here is between an adult and a child we see in the 4-symptom screening is a contact history of tuberculosis. So that anyhow we verify it. If there is any doubt about TB status, IPT should be delayed. It is not a medical emergency to start, restart, and look for this. Next slide. Now, what are the contraindications? The contraindications are the patient should not have an active TB disease or active hepatitis, and signs and symptoms of peripheral neuropathy, if they are there and persistent, then we could probably look into, and heavy alcohol consumption again, which is more prone to aggravate peripheral neuropathy. Concurrent use of hepatotoxic drugs, contact with MDR TB case or any drug resistant TB case, and a PLHIV who had completed DRTB treatment. So these are all some of the contraindications that we need to think of. And most of you know why we are not doing it at MDR or DRTB, because the patient had already will potentially have an infection that will not respond to INH. Next slide. Right. So this is all a workup that we are trying to give in terms of how do we rule out any contraindication. So we need to look out for signs of liver disease in terms of icterus, then neuropathy, if there is a persistent numbness that the patient is complaining of, and any tenderness in the upper right quadrant of the abdomen. And wherever available, if we have a routine LFT or ALT should be performed. So these are all some of the suggestions where we should be looking for any contraindications. But as we say, even when we are looking in the session for ART preparedness or initiation of ART, we have seen that the investigation should not delay any procedures within an ART center, either initiation of any prophylaxis or treatment. So this is one important thing, and we are only saying we need to, this is good to have, but if you do not have, it is better to put a patient on preventive therapy. Next slide, please. So in India, currently, the recommended is INH at a dose of 300 milligrams along with pyridoxine 50 milligrams per day for 6 months. So again, the PMDT guidelines and also the current guidelines, what we are suggesting is non-availability of pyridoxine should not be a reason to withhold TB preventive treatment. This is again very important because there were several operational studies done by NTEP, and these recommendations have flown in from there. Alternatively, multivitamin or B complex formulations with the requisite prophylactic dose of pyridoxine within the general health system may be considered here. So because we hear certain states or some of the ART centers say there's no pyridoxine to start with, but this again is a recommendation where we could take it and offer to most of our patients. Next slide. Now the pediatric dosing chart for IPT, this again is weight based. So again, monitoring of weight becomes very important while we prescribe both ART and any of the preventive treatments for either fluconazole preventive therapy, sorry, TB preventive therapy or CPT. Next slide. So how to follow up? Now, once you initiate a patient on IPT, that doesn't mean that we should not be doing a 4-symptom screening. Even when a patient is on IPT, during every visit to the ART center, the patient should be actively asked for 4 symptoms. And if a patient has at any point of time he has any of the 4 symptoms, then a thorough investigation and questioning into why the patient has 4 symptoms need to be looked into. And if a patient turns to be TB positive during this is known as a breakthrough tuberculosis, and then we need to start a patient on active TB treatment. So this is very important, and we have seen cases, not that it doesn't happen, we are seeing cases of this. So this is one important point that all the staff needs to remember, that 4 is negative, and if you are on TPT, still we need to keep monitoring these patients during every visit. And 4 screening should be done for all patients irrespective on ART. The pre-ART doesn't exist now, but during that initial initiation phase where we wait for investigation or any other thing, even then we should do the 4-symptom screening. Next slide. There are certain specific situations where you come across. So if a patient is previously treated for tuberculosis, for example, a patient has just completed his TB treatment, should we again start TB preventive therapy in this patient? Yes, the patient who had successfully completed TB treatment for TB disease earlier should receive INH for an additional 6 months. So this is called secondary prophylaxis, and we are offering this only to prevent recurrence of TB again in these patients who are more vulnerable. Now, combined use of IPT and ART is recommended for all children and PLHIV regardless of degree of immunosuppression, previous treatment of a TB or pregnancy. So this again is a revision, as we have seen in our operational guidelines sessions too, that now the guidelines recommend starting ART and IPT concomitantly in a patient whom we are initiating newly. Earlier guidelines, we have given that we delay for 3 months and then start IPT, but now concomitant use, where we have seen that due to concomitant use, there is an evidence which suggests that the immunogenicity is higher because of this, and the cell-mediated immunity improves much better when both are given concomitantly vis-a-vis when they are given with the gap of 3 to 6 months. Next slide. So another situation, what we are seeing is a pregnant woman living with HIV should not be excluded from symptom-based TB screening and receiving IPT. Again, most unlearning needs to happen here, that because she's pregnant, she doesn't get TB. That is one notion. The second notion is we should not be doing a TB screening. So this again re-emphasizes that we need to do a full TB symptom screening, and even if required, to initiate on IPT. And it is safer during pregnancy. Now, if a baby is born to a microbiologically confirmed TB mother, assess the newborn for active TB. So usually this is all again a non-specific thing where there is irritability, and if there is a tuberculosis, if there is a high grade of fever with a low birth weight, these are all indications where we could look for or investigate further for tuberculosis. And infants age less than 1 year of age, IPT is indicated only when we rule out contact history, which is very important, and a thorough clinical evaluation like the above symptoms. If they do not have, only then we consider initiating IPT in children less than 1 year of age. Next slide. Now, in contacts with MDR-TB and PLHIV who have completed DR-TB, they are not eligible because INH will not is not going to be sensitive in these patient groups. Now, if a patient develops TB symptoms during IPT treatment, we have already discussed this. We need to, based on DST result, the appropriate treatment should be provided. Now, if the patient is sensitive to all the drugs based on the history of ATT and duration, what we are saying is if a patient has taken TB treatment in the past and has taken IPT for less than a month, then provide the patient with treatment as a new case for IPT. It's not for TB, for IPT. Now, if the patient has received anti-TB treatment in the past, or if the patient has taken IPT for more than 1 month, then provide the patient with a retreatment regimen again. If the patient is found to have DR-TB, refer the patient to a DR-TB center. So this again, there's a slight modification from the previous guidance that we have. And please do remember, whenever we talk of TB here, again, referral to DR-TB center or drug sensitive TB is one we are mostly handling in our ART centers now. Next slide. Now, there is another situation where if a patient had taken IPT for less than 1 month in a total and discontinued for any reason. Now, in these patients, we need to do a thorough adherence counseling, address reasons why the patient has discontinued, and then ensure that we continue or they have completed a 6 months course now. Now, if a patient has taken for more than 1 month and a patient has discontinued for less than 3 months, so what we need to do again here is we need to ensure that the 6 months course is completed within a period of 9 months. Now, the last is very important. If a patient has taken and discontinued for more than 3 months, so here do not reinitiate the patient on IPT because the adherence is really, really low. We need to have a good history and adherence counseling to this patient before we do anything. So in a nutshell, to remember, if a patient less than 1 month, we ensure that the patient continues and completes the remaining course of IPT. And even if it is less than 3 months, if a patient has discontinued and he has taken it for more than 1 month, but less than 3 months of discontinuation, we need to ensure that he completes by the next 6 months, that is a 9 months period. And if it is more than 3 months, do not again give this patient IPT. And this requires a case where we need to look more into the adherence of both ART also in such patients. Next slide. Thank you.
Sir. We'll first take the questions from the chat box and then go for the post test.
I think sir has answered.
Yes, sir
for
is
us.
also responding.
I think we have answered all the questions.
Okay,
I
sir.
don't see any unanswered question as of now.
Okay. Kiran, can you please unmute participants in case there are some more questions?
Done, ma'am.
Thank you. Participants are requested to please go ahead with the questions in case they have any questions now. You can please unmute your mic. Any questions from the participants? Please feel free to unmute your mic.
Yes, ma'am. Ma'am, I want to ask, we start ART in tuberculosis within 2 weeks, but why in TB meningitis it's around 8 weeks? What is the reason?
I have answered this question in the chat box. We start within 4 to 8 weeks, not 4 to 8 months. 4 to 8 weeks because of various reasons. And one of them is because increased mortality due to chances of iris, overlapping toxicity of drugs, and drug-drug interactions. That is the reason. And there is a lot of inflammation in TB meningitis. We might have to give steroids also in some cases. So we defer in such cases for 4 weeks, the treatment of initiation of ART.
Thank you, sir. Participants are requested to please check the chat box. In case you have placed your question in the chat box, it has already been answered. Any more questions? You can ask them now. Sir, I don't think there are any questions. Can I go ahead with the posters, sir?
If there are no questions, please go ahead.
Sir, if we have patient come with the tuberculoma brain,
Yeah.
then we start ART in this patient after 4 weeks, right?
Yeah, 4 weeks. We have to stabilize the patient first on tuberculoma with anti-tubercular drugs. Maybe they required a therapy, decongestant therapy, and to reduce the cerebral edema, and also if steroids if they are required. They will be more required in meningitis rather than in tuberculoma per se. And then you start after 4 weeks.
Okay, sir. Thank you.
We'll go ahead with the posters, requesting participants to please continue posting their questions in the chat box. Kiran sir, can we have the posters, please? Thank you. Participants are requested to please attempt the posters. Again, there are 5 questions, the same questions that were there before. Please scroll the screen and you can attempt all the 5 questions. We have 5 minutes for the posters.
Sir, good afternoon, sir. This is the medical officer, Tirupati speaking, sir. Hello.
Yeah, please go ahead.
Sir, you answered my previous question, but I just want to ask in a general way. Supposing
Yeah.
a person gets he gets TB 2 times, let us say just for hypothetical purposes, 3 times. After every 8 completion of ATT, every time he has to get IPT.
Yes, he has to get IPT after all every time ATT. But you have to see why he's getting TB.
Yeah, I
times.
understand that. I just wanted. I understand.
Yeah. So we have to look for, it is drug resistant TB.
Yeah, I understand. And adherence and other things.
Yeah. Okay.
Participants are requested to please attempt the post test.
Ma'am, post test is not visible.
It's not visible. Okay.
Let's see.
For those for whom the post test is not visible, we'll look into the matter and get back by the next session. Right now, for those whose it is visible, please go ahead. Oh, it's not visible for many. Kiran sir?
Polling section is not there. We have to. It's not for anyone.
No,
So
I have
can
shared
see the
all.
e-poll.
Some people have answered already. 14% people answered.
Yes.
Sorry for the technical glitch. We'll look into the matter and we'll resolve it by the next session. Okay, then so I think we can end the e-poll now. The answers to the questions in the pre-post test. Definition of advanced HIV disease among adults and adolescents includes presenting with CD4 less than 200 cells and WHO stage 3 or 4 disease. Which is the most common OI in HIV in India? It is TB. Which of the following is not included in package of advanced HIV disease management? That's reimbursement of travel expenses, case-to-case basis. Which of the following statements is true for CPT? No specific laboratory monitoring is required in patients receiving cotrimoxazole. Following are the criteria for discontinue fluconazole primary prophylaxis, except fluconazole given for at least 3 months. Thank you. The next session is on 12th of July. And the topic is PPTCT and ART in pregnant women. Kiran sir, can we quickly run the feedback? Thank you. For participants to whom the feedback questionnaire is visible on the screen, please attempt the questions. There are 4 questions in all. The first question is, I found a session conducted under National Guidelines for HIV Care and Treatment 2021 series to be relevant for my practice. The options are strongly agree, agree, neutral, disagree, strongly disagree. Second question, the queries I had about the topic were addressed in the session. The options remain the same. Third question, the information presented during the session was clear and easy to understand. The options remain the same. Last question. On a scale of 1 to 5, how would you rate the session conducted under this series? 1, very poor, and 5 is excellent. Please attempt the e-poll. Kiran sir, we can end the e-poll now. So there's one question in the chat box. If a patient is on fluconazole prophylaxis and if he or she develops fluconazole side effects, what would be the alternate drug?
So we can use other alternative therapies, and one of the alternative therapy could be voriconazole, it could be itraconazole, if there are fluconazole related toxicities.
Thank you, sir. Any more questions from the participants? We can wait for another 2 minutes. Please unmute your mic and ask your question. There are no more questions, sir. Thank you, Rewari sir and Dr. Ramesh sir, for your valuable time. Thank you, Snehalata ma'am, for joining the session. We can end the session now. Thank you.
Thank you.